shown tremendous dedication to this project, this mission that we're on. And she's going to talk a little bit about some of the outcomes we've been able to achieve. And I really look forward to sharing that with you guys.
Good afternoon. You get the postprandial drowsiness, and hopefully I won't augment that, or I might drone down. So Dr. Krieger had invited me to talk, and he really said, I want you to share the most recent outcomes of what we have for MIBEC. So that he was charged with that. So that's why this talk is going to be, I know it's listed as the academic talk, a little bit more sort of data-oriented on what is all this and where has it come? And what I'm going to share today is really just, it's not the very preliminary results that we've had, just because there have been other publications that have shared some of the preliminary reports, but this is our sort of short and intermediate term. So now we've been at this for 12 years, so, really 11 years since the first surgery. And so we took a group of patients and tried to say, what have we learned and what can we then share back to you all and to other families? So when you're meeting new families for the first time, when I do prenatal consultations, I can actually give, show me the numbers, sort of. And now numbers don't mean anything, because, if it could be 2%, but if it's you, I would say it's 100% for that person. But it still gives you a general sense of things. So what is the problem? We all here know the general problem is that it's very hard to go from the picture on the left to the picture on the right. For males, and in females, same thing. Very, you've heard all today but that's our goal, is going from the picture on the left to the picture on the right in a very safe way, and then the long term of what's going to happen. So you've heard from Dr. Krieger about MIBEC and, Boston, Philadelphia, and Wisconsin are involved in MIBEC, and this is the collaboration that was started. But here's, I took out a lot of the nitty-gritty slides. I did try to trim it down. But the overall focus of this was to say, we want to try to have a unified approach. Now, a unified approach, and I could go on and on about this because in this publication, I had many responses to reviewers explaining why a unified approach does not mean the same approach. You just heard, from Dr. Sally, you have to change, because if you're doing the same thing every time, and if it's not working, well, don't just do the same thing just because I did it the way the last time. Don't just do the same thing because, we are supposed to do that per protocol. It's very, very patient individualized, and so you'll see as I present this that not everyone necessarily has the same thing, and so it makes the data a little bit harder to I don't want to say analyze, but to equate. But that's the whole point of this, is that we all got together. We talk about every child that went through and is presented and represented in this work. Every child had their own individual discussion. Every child is different. It's a spectrum. One bladder extrophy does not equal necessarily the other bladder extrophy in how they do before surgery, during surgery, after surgery, and in the long term. And so everything is individualized. However, the data collection part of it doesn't have to be individualized. And so the study is an IRB approved study. And so many of you who, if you were in MIBEC, say, all right, I consent to basically be talked about, but not in a bad way, not with any names, but just say, all right, we're going to try to understand. We're going to record your surgery. We're going to study it if, when things go well. We're going to use those image films to be a game film for the next trial that we operate on. So this is just some of the details that we had at IRB. That's the letter of approval. We have case report forms. So every surgery, there's someone else in the room in the background marking down all the little details, because we all know that you can't remember all the little details. It doesn't mean you have to do it the same. We're just going to acknowledge what was done, who was in the surgery, what was the antibiotics, what was the stitches used, all the little details that we all had met together to decide on what those details. Do all of them matter? Maybe not, but at least they have them recorded. And then the last thing is a follow-up grid. And just yesterday we had our MIBEC meeting, both clinical and patient review meeting as well as research meeting. And said, hey, we have this grid. At least this is what we should be doing for every patient in managing good clinical care, but we also know that sometimes, well, if that's not going to benefit the patient, maybe we don't do it. That's a discussion we'll continue. But at least, everyone needs to get their ultrasound. Everyone should get their labs because we want to make sure we're not missing anything. And so a lot of this is to make sure that every child is getting the same very, very thorough care. And then it's all recorded so then we can look at it afterwards. So in this study, again, focus of this talk is really this 8-year paper that just came out a couple months ago. We looked at two major aspects of care: early complications and then overall later dry intervals. And the whole goal of MIBEC when it started, and every publication that we put out, is to really go into the granular detail of everything we're doing. When you read papers, and I don't expect you all to have read a lot of extrophy papers, but the one thing you'll find is that it's very heterogeneous groups. Different things have been done. There's sort of sometimes a wave of, the same surgery was done, but you really don't know all the details. And so we want to be very transparent in everything that we're doing for the care for every individualized patient. One of the reviewers did say, this reads like a case report. I'm like, that's the whole point, because we want it to be a case report for every child, because every child is different. But that granularity and that transparency is what we're aiming for. So you know exactly what's going on, and by you, I mean you in this room, and you as all urologists and pediatric urologists can know exactly what we're doing. And we want to be able to have these numbers to be able to share with you exactly the small complications. When you had a UTI, had a little bit of skin breakdown, that healed on its own. If you had to go back to the operating room. And then that way we can best counsel families, because then we know exactly what's happened with the last, in this study is 92 patients, and then for the future 92. And then for the second part of our goal was to really focus on dry intervals. Because when you read a lot, again, in extrophy literature, they say continence, yes or no. It's not a binary. So little in this world is a binary. No two people have the same dry intervals. In pediatric urology, you meet whole host of different patients and families, and sometimes they have a child who has urgency, frequency, and we say, well, you pee every 2 hours. And the mom laughs and scoffs. She's like, I wish I could go 2 hours. And that mom has a normal bladder. She was born with a normal bladder. It's just everyone's different. And so when you focus on cutoffs of, you have to be dry for 3 hours to be a quote-unquote success, we said, well, let's put that aside. Let's look at the little details, the granularities, to say, well, how long are you dry in the future? And Dr. Roth is leading a pilot study now. I will say, well, how much are you leaking in between those hours? What are the voided volumes you have? So we're going to get even more granular in the future, but each thing is step by step. But so rather than focus on a yes or no outcome, which is based on a sort of predetermined, I would say physician-determined time interval of 3 hours, let's say, well, is it 1 hour, 2 hours, 3 hours? And we know everyone's going to be different. So just for what we found, so we looked at February 2013 to February 2021. We did that so we could have at least a year follow-up, and the data collection for this began a couple of years ago. And there was 92 children with classic bladder extrophy in the group that we looked at, 62 boys, 30 girls. And that actually is right in line with what we see as a 2-to-1 incidence of bladder extrophy. We noted down whether, again, we didn't do any fancy statistical analysis in this paper. For any of you who do go to read it, we just stated the numbers. And one of those numbers is how many had other surgeries during their initial surgery. And those other surgeries included ureteral reimplantation, where we moved the ureters to prevent reflux. 16 patients had ureteral reimplants during the CPRE. And then 19 boys, it happened to all be boys, had an inguinal hernia repair at the time of the CPRE. And then osteotomies, we strongly believe in osteotomies, and because in MIBEC, again, in our unified approach and beliefs, we do a delayed closure around 3 to 4 months. Osteotomies were performed in 89 out of the 92. And even in the paper, I delineate those 3 children who didn't have osteotomies. It was because they were a little younger than the others. Their bones were very malleable. The surgeons doing the case decided that they weren't needed, but that we have exact descriptions of exactly why they didn't have them. 84 had spica casting, 6 had Bryant's traction, and 2 had external fixation. So the first part of our outcomes are short-term complications. So 31 children out of the 92, which is 34%, had at least one complication within 90 days after surgery. Now go into, that's the table from the paper. We're going to break that down a little. And I'll break them down into sort of what are more mild ones, what are more severe, but either urgent or not urgent complications. And again, we're telling everyone in the country and everyone here what exactly these were. So 10 children had UTIs with a fever. 5 children, I meant to increase the font size and I didn't, has superficial skin breakdown of the incision. That means a skin breakdown that just healed on its own, didn't lead to anything worse. There were 8 children who had skin breakdown from bracing. And I will tell you that I know with our spica casting at CHOP, we often have kids who get rashes all on their legs or their back or their arms, and all of that was included. Now, all of those healed with either just topical treatment with like Vaseline or sometimes a fungal cream, but those were even included in here. Whereas these things often you're not going to hear about in larger series or other series of the little things that can go on. But it's those little things are still things that each child or those children experience. So we want to make sure that we can tell families that that's something that can happen. And then transient urinary retention in 3. So initially, the baby wasn't able to pee after surgery, but kept a tube in, a suprapubic tube in for longer, and then ultimately peed on their own with no other interventions or minimal other interventions, which I'll get into. What are the more severe complications that can happen after exstrophy, which again, from that first picture, and everyone here knows, it's a big surgery. And to expect a big surgery to have no complications is unrealistic, but also we strive to do our best to prevent any of those, but they can happen. So there were 2 children who had abdominal dehiscence, which means their abdominal fascia, the strong layer opened, and they had to have emergency surgery afterwards to close it. But both of those 2 children, their bladders stayed intact, their bones stayed intact, and they healed without any long-term concerns from it, but it was a major and scary thing for those families and their children and for their doctors. Bladder outlet obstruction. So when the urine wasn't going to pass through the urethra, and there's one going to the procedures who even had a more serious complication from not being able to empty the bladder. And meatal stenosis, probably leading to some of that transient urinary retention, but all of these things needed more urgent intervention, like a cystoscopy and dilation of the urethra. And then the more severe ones, but not urgent, that occurred are long-lasting urinary retention in 4 children, and then urinary fistula. So fistula is when there's a connection from the bladder or the urethra to the skin, and that happened, it was 10 in total, 8 to the urethra and 2 to the bladder. I will say, but we didn't go into this in this study, but in future studies we will report that some of those did occur earlier on in our series, and then much fewer later on, due to some changes, because as I said in the beginning, we change, we modify. If something is not ideal, we're going to change, and so that make it less likely to happen in the future. And then the reviewers can complain that we didn't do, sorry, I hope you're not all reviewers. I'm a reviewer too, so it's against me. Yes, we didn't do the same thing for every child because we can't keep on doing the same thing. If we notice something that maybe wasn't perfect, we have to continue to change. So in the first 90 days, 13 children, 14%, did return to the operating room for some procedure. 7 of those children had cystoscopy. I should say these are not necessarily children who had them. 7 cystoscopies were performed because sometimes it was 2 in the same child potentially. Some with a urethral catheter placement. That was 4. Meatoplasty, opening the meatus, and 1 suprapubic tube change. The child wasn't doing perfectly, not ready to take that tube out. Have to get the tube changed. We're even including that in our short-term complications, which often wouldn't be mentioned, but it's a trip back to the operating room. It's a stress on the family. It's a stress on the child. We include that. And then removal of a retained, it's called a foreign body, but it's a retained stent. 3 children had a hernia repair. Those children either didn't have a symptomatic hernia at the time. There's variations in practice of whether we do repair hernias at the time of surgery. 3 children had to go back to the operating room for a hernia that presented within the first 90 days after surgery. There's 2 that had a repair of abdominal wound dehiscence, which you heard about. And the 1 urinary retention that was more severe resulted in an internal bladder little perforation, and so that was had repaired. We did also look at, all right, well, what if you didn't meet the cutoff of this happening in 90 days? I still want to be able to know, for us to know and to share with families what happens in the first year. So from 6 to 12 months, an additional 20 children went to the operating room. 7 children had ureteral reimplantation. If they didn't have it at the time of the CPRE, but we felt like it would benefit them within that time, they went back to the operating room. Another 6 children had hernias that they had to go to the operating room to fix. 4 more cystoscopies were performed. Ones were for just to look, but again, we included that in our return to trip to the OR. And one had with a urethral dilation to open, sort of like a meataloplasty, but just spreading with a scope. There's 2 fistulas that were repaired, and 1 child with persistent urinary retention and UTIs underwent a vesicostomy in that time. So that's going back a second. So this is sort of the short-term outcomes. That was our goal, to just be very transparent and very granular in the detail of what exactly happens early on after surgery. And then the next big question is, how do they pee? To me, pee is a technical term. So that's a question always on everyone's mind, and all these papers are looking for outcomes. And we acknowledge that this is still a very early series. And when we're talking only about 11 years, by that time it was 9 years that we had follow-up. You can't even take the whole group because not all of them are old enough. If you're 3 years old, my 3-year-old still pees in a diaper and says, I'm too young for that. So you can't compare 3-year-olds, 4-year-olds to older kids. However, we did use 4 years old as the cutoff to say, all right, we're going to look at kids who are 4 years out at least and see where they are. Now, that's still, we think, very early, but we decided to have enough children to look at, we would do that. And so this part of the study is very preliminary. We call it intermediate term because it really is. And so the next 5 to 10 years, we'll have to look back at these children. So this is sort of the general breakdown of where kids are, again, breaking down by numbers. So 45% are wet. They have less than 1 hour dry interval. Maybe they have 30 minutes, which actually in a 3 or 4-year-old might be great. But we said, all right, less than 1 hour, you're going to be in the less than 1 hour group. There's a small 10% that are unknown, and you'll see we just didn't have that granular enough detail for those. However, you look on the right side, in the green ones, that 28% of kids, again, over 4 years out, so it could be 4, 5, 6, 7, 8, or 9 years, had greater than 1 hour dry intervals. Another 10% had greater than 2 hours dry intervals, and 7% had greater than 3 hour dry intervals. But we did then break this on. So this is out of 46 patients that we're looking at, because those 46 had 6-year follow-up or up to 6 years follow-up, and 40 of those had continence data. We do have some patients that we didn't have all their data in the record, so we had to exclude them. But I will have one comment at the end of someone who I've kept in touch with. So looking at those 40 patients, we divided it into sort of who's void and who's not voiding. Because that's the other thing. In MIBEC, just taking a step back, we really try to break down the difference between continence and dryness. Now, early on, we had a lot of discussions about this, and it is sort of all semantics, but to make it a little clearer, we think of, all right, continence is truly the ability for the bladder to hold and then to squeeze and empty. Whereas dryness, and have sort of be dry underneath. Dryness is the ability to hold, but not and not leak, but doesn't necessarily include the part of emptying. So you can empty with a catheter, or usually, with a catheter either per urethra or through a catheterizable channel. But there's a break point between the continence and dryness only because, again, you've now changed the path for that child. And so we try to separate it in our tables and everything. We look at overall 40, but we acknowledge the difference between those who are actually voiding and those who are not. So of the 33 who do void, it's 33 of that 40. Again, dry 1 to 2 hours, there was 11 children. Dry 2 to 3 hours, there's 3 children. And dry 3 or more hours, there was 2. But then if you add on those who are on CIC or one had a vesicostomy, there's very few who are dry 1 to 2 hours, 1 dry 2 to 3 hours on cathing, and 1 dry greater than 3 hours. And now not all of those, I will say in this cohort, I just want to acknowledge that none of these children had augmentation or bladder neck closures. There was one, let me see if I have this here. before I go back. I'm going to skip ahead, sorry, for 1 second. No, don't go there. Maybe I'll go back to that in a second because I'm not remembering if I added that in there of other surgeries that they had in the time. They might have had a bladder neck reconstruction, but not bladder neck closure or augmentation. So now of the 40, you could take it the other way. It was joked that I'm a pessimist, and I'll say the ones who are not doing well first, whereas Asim is the optimist in our group, and he says everyone who's doing well. But so if you take the other side of view, there's of the 33 who are avoiding, there's 15 who are not dry, even an hour, and 3 who are unknown. But those are the ones we'll take a look at how old they are also in a second. So of those going back to the ones who are dry 1 to 2 hours, 2 to 3 hours, or 3 or more hours, this is where I have it. So if you want to say voiding with a dry interval, there's 5 children out of 40, only 12.5%. But again, we're looking at children who are young. And if you say, well, let's look at a little bit more open about it, and you say if they're young but they're dry for over an hour, hey, that's good potential. I think you heard earlier from Dr. Groth about potential. And so that's 16 out of 40, or 40% are already dry at a young age for greater than 1 hour, and they have potential to go longer. And so when you break it down by age, this is what I was looking for. Though on the left, it's 4 years out from surgery, and assuming that the surgery was done around 3 to 6 months, they're probably 4 years or more. 4 to up to 9 years. Of course, there's fewer that were already 9 years out. You can see there's a wide range among the different levels, but those in the pink that are less than 1 hour, about the same, but there's more greens, yellows and greens, as you get a little bit older. So one of the things, and there wasn't enough numbers to show here a good trend of, older is better, but we're also just getting to that prime age around 8, 9, 10 years old where we think that people will start to have more bladder growth, maybe get a little bit more strength and more dryness. So again, in 5 or 10 years, we'll be able to show this a little bit more of where they are. So those, if you look to our previous numbers, and back in 2020, we published pre-MIBEC numbers of, all right, before we started our collaboration, where were we? It was about 20% who were dry for more than 2 hours with a single surgery. So our number now over 2 hours is not that different. But those children that we had looked at back then were all older. They're all over 10 years old. And so if we're saying it's not that different, maybe the same amount of percentage dry for greater than 2 hours, but these children are younger than before, so they still have potential. They're still, gaining in their bladder capacity and in their strength that we hope will help them to be drier over time. So I did have one update happened after the data for this was pulled. There was one girl with a bladder outlet obstruction with a vesicostomy that was listed here. She was not included in the continence data because she actually wasn't followed with us anymore, but she has gone on to a bladder neck closure and augmentation. Again, that'll show up in the future, so we can't say that we've never augmented anyone. She moved to a different center, and I think that was the right thing for her because of the bladder outlet obstruction. And there's one girl with a bladder outlet obstruction and a vesicostomy who actually closed her vesicostomy last year, and she's now voiding, and with a lot of PT, and she is a karate guru. She spends 3 to 4 hours, she's like 8 years old, 3 to 4 hours training every day, and she's very strong and very motivated. She already has gone from having constant dripping to about 30-minute dry intervals, just with her pelvic floor physical therapy. So we're hoping that she'll come into this group at the next iteration. So in summary, we do know the granular details of what we're doing, and when you're part of MIBEC, we're looking at all these numbers all the time, and we want to share that. And so we know what the complications are over time. And as I mentioned, it wasn't in this paper to show that they've decreased over time, but I know by looking at all the data is that they have decreased over time. And so we do believe we're doing better over time, which is everyone's goal, is to constantly do better. While we're all here, is to constantly do better and better. And we also want to be very transparent, objective. We want to share the results in a clear and very honest way. And just like everything in extravy, it's a challenge. It's rough. You've heard all of that, but it also, as long as you know, and the kids are saying we want to know what's going on. This is the way that we can give the most information to everyone. And as it, we'll bring this data back in another 5 to 10 years, and then we'll know the real impact of everything we're doing within MIBEC and in our care for children with extrophy, and to see if we can continue to push the needle along the way. So I'll leave room for questions. There's a picture of Dr. Canning, one of the last MIBEC picnics at CHOP. Thank you. So we have some time for questions. Yes.
For the pre-MIBEC, was that all 3 of the centers added together?
Yes, exactly. We had looked back and gotten separate IRBs to do retrospective review at each center and gathered all of those. I can show you that. I just removed it from this doc, but.
You mentioned osteotomies in a high number of patients. Can you speak to the benefits of that or strong feelings for why it should be?
So in classic bladder extrophy, as we know, the bones are externally rotated, and in order to bring all the soft tissue together under minimal tension to allow for healing, we believe that osteotomies are important. Now, there was thought that if you do the surgery within the first 3 days of life, which was had been previously done, that there's enough oxytocin to allow for malleability of the bones, that you don't need to do that. However, also in personally even discussing with Dr. Gearhart, the main leaders in extrophy, when he was our VP years ago, he said, oh, well, if the bones are really far and not malleable, even in the newborns, he likes osteotomies. And so he strongly also, believes in osteotomies. And I think that people have shown that your fistula rate and your dehiscence rate are probably less if you do osteotomies. And because we do a delayed closure at like 3 months, and I say like 3 months, and that wasn't just a slip of, a way of talking, but it's a wide range, anywhere in our study from 2 weeks to about 4 months. The bones are no longer going to be malleable, and we need that to pull them together. Now, the bones will come apart over time, and I'm going to show that I keep on saying it's coming, the draft is coming soon, and it really is. They do drift apart, but not all the way back to where they were. And then while the number might continue to grow, the overall rotation of the pelvis is improved from what it was, and that just continues to grow. And so that's, again, for why we do it. Now, in some settings, we'll also do it in epispadias, and very oftenly, because especially if epispadias has a wider diastasis, to try to recapitulate the more normal anatomy, and that's also putting the pelvic floor anatomy into maybe better location. Travis. Sure. And again, that wasn't included in this study, but definitely from the outset, when we meet new families with extrophy, we counsel that potty training is not necessarily going to occur on the same time frame as another child born with the bladder intact. And there's a couple reasons for that. No, yeah, I'll take a step back. So the couple reasons for that, in that the bladder in development, when the bladder starts forming at 9 to 14 weeks, you can see it around 18 weeks, and you should be able to see it in utero, has the next 4 or 5 months to stretch and to grow, and it's going through that natural cycling. And we know that the body in utero develops at a much faster rate than postnatally after birth. And so to expect a bladder to grow as quickly and as well as a bladder that had that 4 or 5 months in utero to grow I'll say it's not fair. Give these bladders a chance. And so, when you close a bladder, it needs more time to be able to cycle and to grow and to gain elasticity. And there are thoughts, and we were just having a nice conversation in the back table, that certain medications can help that bladder to grow over time. But either way, you can't expect the bladder to act the same way and by 3 years be big enough to hold the amount of urine that a 3-year-old is making and be the same capacity. Now, that said, I do have some kids who are 3 years old where their bladder capacity is exactly the same as what another 3-year-old's capacity is. So it can happen, but I just feel like you can't expect that for all comers. So that's one thing. The other thing is there is some element of needing extra strength and extra muscles to train the external sphincter in extrophy because it was open and now you've brought it together, and that's the signaling there may not be all the way the same. So you can't expect a 3-year-old who might be able to toilet train, you know, in a non-extrophy child to necessarily have that control. But that's also where we have a big emphasis on pelvic floor physical therapy and therapy as kids get older, that we know that that can help those muscles to gain control. But a 3-year-old is definitely not the same as, you know, a 10-year-old, and a 10-year-old is going to be much more able to do these things. The last thing is, you know, I also, when I talk to families, say, all right, you know, you can potty train for poop, it's just not for pee. But even I found that some of the kids, even though pooping is totally, totally normal in kids with classic bladder extrophy, or maybe a little, you know, closer to 4 years old before they're potty trained for poop. So you don't even think of doing anything with the bladder before then. But I do encourage, I think to me, potty training, there's a developmental, and mental might not be the right word for it, but sort of like there's the cognitive part of it, and then there's the bladder part of it. And the cognitive part of it is stopping what you're doing, which is very hard for a 3-4-year-old to do, and going to a private place and taking care of your body. And, you know, and I always say emptying your bladder by whatever means needed, and maybe it's already empty and you're just changing a pad or diaper. And then there's the continence part that in potty training of actually holding the urine. But I definitely meet some families who, they've never tried that first part. Because they're, oh, I've always been in a diaper, I just change the diaper when it sort of feels full. But I do think, again, this might be just totally me, that sort of, that normal developmental part of potty training of stopping what you're doing, going and changing or whatever you're doing is very important. And the kids can do that at a, you know, age-matched, same age as anyone else.
Can we turn the can we turn his microphone on, the mobile microphone? Now try it.
Hello?
Yes.
Thank you very much for a very honest and well put talk. I wanted to, since you have such a beautiful database, I wonder if you can help me to answer a question that I've been telling sometimes to the parents when the baby is born with extrophy. And they come terrified with the huge bladder bulging. And I said, wow, that's great, because this bladder that is scary for you is actually the best thing, best news. Because you can imagine when big bulging bladder, if you close, you're going to have a good capacity bladder. Probably it's going to have a bladder that will develop, probably has high chance of continence. So I say that, and I hope I'm right when I'm saying that, that's why I'm a question. The other way, sometimes I don't really say because we get surprised with a very small plate, and still sometimes they grow, but I'm not as happy when I see the big bulging. My question to you is, since you have this beautiful data, did you put together the size of the bladder plate, elasticity of the bladder plate with outcomes?
So that's a great question and is a great lead-in. The answer for this study, no. However, that's been in the works, and Ted has a abstract at the SPU this year looking at bladder plate sizes, Ted Lee. And we do want to look at, the problem is how do you measure it? And I'm known for being the nitpicking detail person, but also sometimes saying, you know, numbers can vary depending on where you put a measurement. And so what is the best way to do a measurement of that bladder? So I do want to combine, and we have a lot of this, the numbers of the measurement as well as the pictures of the bladder, because we have pictures of everyone. So we can say, and we have data on smooth or polypoid. We do have that, but we can do a combination of numbers and sort of texture of the bladder. The problem with the outcomes, and again, temporary problem, we'll figure it out and we'd love to discuss more, is what is the best way to determine the bladder capacity? Is it a sleep under anesthesia pulling, you know, occluding it, and which is probably the right way, but we haven't done that for everyone, but we can. And what age do we do it? Do we do it at 3, 5, 10 years? We had a meeting yesterday and said, all right, maybe at 10 years, we're going to make sure to get the absolute bladder capacity of everyone. But to be able to say, you know, dry intervals maybe will help, pad weights might help, but what's the best way to determine that bladder capacity? And right now, we don't have the best bladder capacity numbers because it's either invasive under anesthesia, occluding the bladder neck, or it's more functional with urodynamics. But there's, then the child might be not as comfortable. They have a SP tube. It might not be an accurate way. But that's the next thing that we've been talking about. Ted and I have our, and MIBEC has our research meetings once a month, and it's on the docket.
There's a question actually back in the room.
Oh.
How can the parents have access to some of these abstracts or peer-reviewed papers that you guys put out?
I don't know the answer to that.
That's a great
Yeah.
question. It's available on PubMed, right?
Yeah, it's on PubMed, but I don't know if you don't have access to PubMed.
Maybe we should start. Oh, okay, I'm so accustomed to it.
That's a great question. It's something we can talk about and try to figure out if there's a way that we can at least get the abstracts posted somewhere. And again, PubMed you could always Google, but you don't necessarily know who to, the names and everything to put on there.
Good idea.
It's a great idea, a great question, but I'm sorry, I don't know exactly.
We need to do better.
Institutional access to these papers, but if you email them, most often than not, they're going to email you back with the manuscript attached. I think that's actually a great idea for us to create some numbers and data for parents and prospective parents to look at to give them some understanding of what they're dealing with.
Thank you so much.
Yeah, thanks, Dave.